And so let's talk about the question of private insurance. A lot has been made of this. What is the principle here, or I should say, sort of the I guess structurally speaking, what is the problem with private insurance?
It's inefficient and it costs a lot. It costs a lot more to insure somebody privately than it does through a larger risk pool, through a larger single payer, or a thing like Medicare, even Medicaid. And they lose a bunch of money because they want to offload sick people. And it results in worse outcomes.
Okay, no, but what I mean is in the context of we set up a single payer system. Everybody's paying their taxes into this, okay? And employers are paying taxes. Maybe middle-class folks are paying more in taxes. Wealthy people paying, hopefully, much more in taxes. The net to society, as we know, is going to actually be we're gonna save money as a society on healthcare, and as individuals, I would imagine the vast majority of us, well over the vast majority of us, are going to be saving money net in terms of what we pay for healthcare over the course of our life versus what we'll pay in taxes. With that, if that is the case, is there a problem if somebody goes out there and says, well, I'm starting a private insurance company? Why would we care as long as, or let me put it this way, would we care as long as people have to pay their taxes and they can't opt out of the risk pool? I don't know why somebody would start a private insurance company, but if they did, what difference would it make, or would it?
So ultimately that results in stratified care, which there's a track for the private wealthy who are probably buying the private insurance, and there's a separate track of care offered for people in the public plan. A great example of this is South Africa. South Africa has a kind of two-stream model, which there is a public plan everyone buys into. But if you've got the money, you pull out and you can buy a private insurance plan. And that gets you private insurance coverage, which is much more expensive at hospitals. But that means maybe you get a private room, or you get VIP treatment, or you get certain kinds of things that you want access to, kind of the luxury model. And the result is that in South Africa, I think it's 16% of the population spends 43% of healthcare costs, and that population is predominantly white and predominantly wealthy. It kind of created actual medical apartheid in South Africa all over again. Whenever you have a kind of duplicative insurance model, it's going to tilt towards favoring people who have money, who will get.
Tim, I'm sorry, we lost you again. You there? I'm sorry, we lost you. Yeah. Right, we lost you right after you said whenever you have a duplicative model.
Yeah, you're gonna have people receiving private luxury care at the expense of the public option in the public model.
How does that come at the expense of the public model? Just because doctors will take themselves out of the public program because there's enough money there in the private one?
Yeah, you create options, you create facilities just for private insurance, because hospitals can bill the private insurers more because they don't have any cost-saving powers.
And do you think that we would? I mean, let me put it this way: from my perspective, I don't see that as we have as much of an opportunity for that type of problem as South Africa does, right? I mean, for some fairly obvious reasons, it seems to me. I mean, in South Africa, you've literally had a dual track society for decades. And in this country, there's certainly been, we already have that sort of high-end wealthy stuff, but there's just not enough of those people. Is there? For them to drain that much resources out of the system?
I mean, I hope not, but I also don't want to find out.
Right. I guess from my perspective, from a political standpoint, I can't help but wonder if that's not a decent trade-off. But why wouldn't it be? I know
we can't legislate away people providing supplemental insurance, right? Like we can't stop insurance companies from existing to sell insurance on top of the single payer. That doesn't duplicate any of the existing single payer insurance coverages. And I think that will probably still exist, and that will go to predominantly wealthy people. I don't quite know what it'll cover, but that will surely exist after a single payer is passed. And that is a thing that I don't love, but don't think we can stop.
Okay. So when we talk about that supplemental insurance, that's if they want private rooms or, I guess cosmetic surgery or, something like along those lines. Is that what we're talking about?
Yeah, things not covered by the single payer.
And so,
because both Jayapal and Bernie's bills include a provision that no provider can provide care to a person not covered under a single payer that is covered under a single payer.
Okay, I see what you're saying. So if I'm going in and I'm getting I don't know any number of any type of treatments, if I'm going in to check and see if I have a heart attack, I can't have a private insurance that will cover that because it's going to be covered under Medicare.
Right.
Okay. And how localized will these programs be? In other words, it's one thing to sort of say that Medicare sets the rates, or how will this money be distributed? What would be the mechanism here?
Well, I can tell you what I want. There hasn't been a whole lot of like in the Jayapal and Sanders bills. There hasn't been a whole lot of here's actually how we pass up the money. But I can tell you what they indicate and what I think is totally essential to having a good single payer program, which is you want the money allocated as close to the ground as possible. Simply because healthcare needs are very different from place to place. Healthcare needs in Manhattan and Brooklyn are different. Healthcare needs in Brooklyn and Birmingham are different. Healthcare needs in Birmingham and, Boise and Dallas and Las Vegas are all very different from each other. So you want to have a healthcare model which determines how to spend money and where to spend money and what programs to fund that is as close to the ground as you can get, which is kind of a model off the Medicaid program and some of the individual Medicaid grants that have been investigated or explored over the past decade. You want to set a standard for these things are covered that is set at the federal level, and make sure all the financing is federal, because if financing is local, you run into problems. Even a little bit of a cost borne by the state becomes a great way to begin excluding care. But I think you want to let regional organizations determine how you invest money in local ways, whether it's approving new programs for housing or for food, experimental programs for coordinating care, or hiring social workers to work on pregnant people, or applying for new money to try new kinds of programs that can then be shared across the rest of the country. I believe Jayapal's plan does include a local component. It includes local assemblies and local councils, although they don't really define what local means. It could be state by state. It could be even smaller than that.